Hey EBM listeners, my name's Salim Razai. I'm a clinical emergency medicine physician in the community down in San Antonio, Texas. I work for a group called Greater San Antonio Emergency Physicians. I might be a little bit biased, but I think it's one of the best groups in the world. I've been working with them for 4 years. I've recently given some updates on COVID-19 and people have been asking for the slides or for some type of video. And so I thought I would put a two-part video together, and this will serve as part one. And it's essentially COVID-19 and evidence-based medicine take. And this is being recorded on October 13th. So anything that comes out after this just will not be on this slide set and may require me to do further videos in the future. But I figured we might as well see where we're at with the evidence base for COVID-19. Now, there's nothing that I'm going to be talking about today that I'm being paid for. I have no financial conflicts of interest. I just run my Rebel EM website, which is a free blog that kind of keeps people up to date with current evidence as new research comes out and how to apply that at the bedside. For part one, we're going to cover 5 topics. And the first question that I get quite a bit is when to change practice. So when do we know, based on the evidence that we're getting, when it's safe to actually change our practice? The second thing we're going to talk about is N95 reuse. And it's crazy that we have to talk about this, but we have to keep ourselves safe on the front lines. And so we're going to go through some of the evidence for that. We're going to talk about corticosteroids, which I think has the best evidence base for it at this time. We'll talk about Remdesivir and kind of where we're at with that. There's now been several randomized clinical trials. And then finally, we'll end with convalescent plasma for part one. For those of you who are interested in part two, we'll be going over anticoagulation. We'll talk about awake proning, invasive mechanical ventilation, ECMO, and then hydroxychloroquine. Those last few topics are a little more controversial, and I suspect everyone's interpretation of that evidence is going to be a little bit different depending on the system they work in and the patients that they've seen. So let's start with topic number one, disinformation and when to change. And this has been a real problem with this pandemic. As we're getting all these preprint publications before they're peer-reviewed, we're getting all these retractions, and we have this huge thirst for knowledge, and we want it as soon as possible so that we can do the best that we can for our patients. But the problem becomes is if we shift too quickly, things get retracted or things get peer-reviewed, and then we've been doing the wrong thing the whole time. And for me, this boils down to evidence-based medicine, and it's still the 3 pillars, even in a pandemic. I know it's a little bit harder. The research is not as good. The clinical judgment, as we're learning about a new disease, maybe is not where it should be. And patient values and preferences, I think, pretty much never change. I mean, they want to have a good quality of life and have good survival. So clinical judgment has a learning curve. Patient values and preferences doesn't really change, but let's talk about the relevant scientific evidence for a second. So in an ideal world, there is usually a theory or a hypothesis that gets developed. Then that gets tested in the lab with animal models or bench research. Then we start doing these small human trials. Then we get to larger randomized clinical trials. And then hopefully those larger randomized clinical trials get repeated to show us that the results are similar between different studies and different populations, getting us closer to the truth, to the question that we're trying to answer, and then ultimately a meta-analysis. Now, obviously, it doesn't work like this. It's not always a pretty bubble. Sometimes we have to use what's best available. And that's exactly what's happened in this pandemic, is we have what's called the best available evidence. All we have are theories, hypotheses, animal models, and small human trials. Now that we're several months into the pandemic, we are starting to see some randomized clinical trials, but at least early on, this was not the case. So for me, this is best available evidence, not so much relevant scientific evidence, and we have to decide what exactly we're going to be doing for our patients. And for me, this really boils down to this big dilemma of, do we make the change now or do we wait a little bit longer? Because we don't want to not do something for our patients, but we don't actually want to do something that would potentially harm them. And this is not a dichotomy, just to be fair. This is more a spectrum. So if we do nothing, then we're potentially underestimating benefit and we're overestimating harm. If we do something, then we're overestimating benefit and we underestimate harm. And I've got to tell you that most of us are doers. We went to medical school, we went to practice medicine to do something for patients. And so most of the time we're overestimating the benefit and we're underestimating the harm. So when do we actually change practice, right? That was the original question I was trying to answer. And I think this is where the hospital system has to really get involved. We have this expedited thirst for information, and with the rapidity of the pandemic and leading to these abbreviated non-peer reviewed publications of unvalidated data, retractions, and dissemination through press release, this is really going to require the hospital system to get involved. And I feel like my hospital system has done a really nice job with this, and I'll get into that a little bit more. On an individual provider basis, I want to know that whatever I'm going to be doing for my patients is readily available, it's low cost, and there's minimal to no harm, at least assumed minimal to no harm, based on what it is I'm going to do from previous evidence. Now, how does the hospital get involved? This is where committees need to get put together within the hospital, and these are multidisciplinary. You get people from the emergency department and the ICU and infectious disease and cardiology and administration and pharmacology. You have these people get together and you talk about the best available evidence, which isn't these large randomized clinical trials, discuss what the system has and doesn't have, and then basically set a standard care within the system so that everybody is communicating and everybody is on the same page. And then that takes a lot of the willy-nilly out of it and the what to do for patients. And so the EBM pyramid doesn't really change. And when looking at the Venn diagram in the middle of a pandemic, when the evidence isn't robust, hospital administration, multidisciplinary discussions is where it's at, and how you decide within your system to make change. Let's talk about PPE decontamination and reuse. And so what I'm talking about here is basically N95s. And this is really sad that in the United States, at least, we're having to talk about reusing these masks, because these masks were not created for reuse. They were created for one-time use. And when we talk about decontamination and reuse, there's really three things we want to keep in mind. Number one is whatever we're doing, is it going to kill the virus, which is what most studies focus on. But what they forget to mention is, does what I'm doing to kill the virus affect filtration and fit of the mask? Because if you don't have good filtration and you don't have a good fit, even if you kill the virus for the first time that you decontaminate, it's not going to be beneficial for the next time you wear it into a patient's room. And so really there are 6 kind of main things that I've come across, and this is a big, dark, black hole that I went down for 2 weeks just reading paper after paper after paper, trying to understand N95s and all these different mechanisms of decontamination and reuse. And let's just assume that all 6 of these kill virus, and I can confidently tell you they do after reviewing the evidence. So then the question becomes, how long do I have to do whatever it is to decontaminate my mask? And how many safe reuses do I get before the filtration or the fit start to become affected? The top 3 on this chart are vaporized hydrogen peroxide, UV light at a range of 260 to 285, and a time-based strategy. Now, of those 3, vaporized hydrogen peroxide is going to be the fastest. UV light will be the second fastest, and a time-based strategy obviously is going to take several days. Now, in terms of safe reuses, you'll get about 3 safe reuses with vaporized hydrogen peroxide and UV light. In my hospital system, we're doing UV light. I personally am doing a time-based strategy, and we'll get into that one a little bit more and why I use that as opposed to what my hospital system does. You get about 5 reuses with that, and I'll do the math for you here in just a second about why that is. Autoclave at 121 degrees Celsius and dry heat at 70 degrees Celsius are going to be our next 2 best options. 15 minutes for autoclave, 60 minutes for dry heat. And depending on what paper you read, you'll get about 2 to 10 reuses with autoclave. I like to be conservative here because I want to keep everybody safe. I want to put out information that is factual and that is going to keep frontline workers safe so that we don't get contaminated. And so I'm going to err on the side of being conservative and say 2 reuses here. But there are some studies that go all the way out to 10. So the reason these are the second best is because you get slightly less reuses with these modalities. Now, the dry heat, this is not your oven at home, okay? This is a very specific oven that has an internal thermometer that can keep track of exactly how hot that mask is getting from second to second. So don't be doing this at home and cooking your mask, because you will ultimately affect the filtration and the fit. And then there was a lot of publications on the 70% ethanol spray. And although it's fast, 10 minutes, the problem is it affects the electrostatic charge of the N95 mask, and you get 0 safe reuses with it. Now, I told you I do a time-based method for N95 reuse, and we've done studies on COVID-19 and coronaviruses, and we know that after about 72 hours, if the virus has not found a host, then it's no longer viable. And that's essentially what you're doing here. You're not using pressure, you're not using UV light, you're not using heat. You're basically just letting time make the virus inactive. And so if I was working a shift on April 15th, for example, I would wear that mask the entire shift. I would come home, I'd put it in my garage, and I would put a label above it that says, I used it on 4/15, and the next time I can use it is on 4/19. My next shift, let's say, is the next day, because I have a string of shifts. I would do the same thing. I would use that new mask for the entire shift, and then I would bring it home, and same thing. I'd put a label above it and a label below it. So there's no confusion about what I'm doing with these masks. Now, why 4 masks? Because I never work more than 20 shifts in a month. And so if I get 5 reuses, 4 masks will get me through an entire month, which is a great way to kind of preserve these masks, but would require you to get 4 new masks every month. So very, very feasible. I've been doing this, and for the record, I have had my antibodies tested, and so far, no go. I have not yet caught COVID in the months that I've been on the front lines. I'm going to give you guys some QR codes throughout the video that give you links to blog posts I've written, references to what I think is the best evidence, early evidence, and kind of current evidence. And so this is the best post we have that reviews the evidence of all these different techniques, and it basically has everything there for you in graph form, broken down by the stats. So if you want to nerd out and you really want to get into it, there you go. It's right there for you. Just hold your camera up to the QR code and it should take you directly to the link. All right, so this is kind of a hypothetical model that I want to present. This has not been validated. This is just kind of my construct in my head. And I think this is important when we talk about patients coming in with COVID-19, because the treatments that we use are going to be dependent on where they are in their illness. And so imagine for a second, in an ideal oversimplified model that I'm presenting to you, that days 1 through 5 are going to be the viremic phase where the virus is just replicating. Days 5 through 10 are going to be the pulmonary phase where patients start to get a little dyspneic. And this can even be subdivided into an early and a late phase. The early phase basically not requiring oxygen, and the later phase requiring oxygen, high flow nasal cannula, non-invasive ventilation, oxymizers, or whatever other strategy you're using. And then days 10 to 15 are our kind of inflammatory or hyperinflammatory phase where patients are requiring invasive mechanical ventilation, ECMO. They're having multi-organ failure, requiring multiple vasopressors, myocarditis, these sorts of things. Basically, these patients are the sickest of the group of COVID patients that we're going to see. And the reason I mention this in terms of a construct is that the treatment choice that we give our patients is going to be dependent on the symptoms, the duration, and where they fall in this paradigm. And so again, some patients, day 1 to 5, their viremic phase may be days 1 to 3. It's obviously oversimplified, but it's an important construct to keep in mind because the treatment we choose is going to be dependent on this. And you'll see this as we go through the evidence. So let's talk about dexamethasone, or just corticosteroids in general. And I think the best randomized clinical trial we have on this is from the recovery trial based out of the UK. And this was a big paper. This is probably one of the biggest early randomized clinical trials we had, also one of the most positive that we've had throughout this pandemic. It was 176 hospitals out of the United Kingdom with over 6,400 patients, and their primary outcome was 28-day mortality. And what they found is that patients who got randomized to dexamethasone 6 milligrams compared to patients who got randomized to placebo, what they found is a number needed to treat of 33. So for every 33 patients we treat with 6 milligrams of dexamethasone, we have a 28-day mortality benefit. And on a large population scale, this is not an insignificant number. Now, what I found more fascinating was when they broke this down into phases of illness, which is what I kind of presented to you at the beginning of this. So the green box is 28-day mortality in patients with invasive mechanical ventilation, what we would consider our hyperinflammatory state of disease. This is where we saw the biggest benefit of dexamethasone, number needed to treat of 8.5. The second box is our pulmonary phase of disease, 28-day mortality requiring oxygen, but not invasive mechanical ventilation. And you can see here the number needed to treat here is 29, so not as good as 8.5, but still a benefit. And then 28-day mortality in patients not requiring oxygen, not requiring invasive mechanical ventilation. And although not statistically significant, there was a trend toward harm. And this would kind of be that viremic phase of disease. Maybe we are suppressing the immune system and not allowing it to fight off that virus that's replicating. This is a secondary outcome in that study, looking at duration of symptoms with a cutoff of 7. And let's be honest, that's a little oversimplified, but it still drives the point home. And looking at whether we treated before 7 days of symptoms versus after 7 days of symptoms, and looking at 28-day mortality. And what they found is that treatment earlier actually did worse than treatment later. And as you can see from the model I presented at the beginning, this would be our viremic phase and our early pulmonary phase where we're not requiring oxygen. And so those patients actually were potentially doing harm by giving them steroids. And then once they kind of get into that oxygen requirement and higher, the late pulmonary phase and inflammatory phase, that's where we're seeing the biggest bang for our buck. So this is that breakdown of the recovery trial looking at dexamethasone. I wanted to leave you guys the QR code for that. I basically break down all the stats for you, and hopefully you guys have some fun with that. Now, I originally had put this talk together, and late in September, 4 trials got published in one day, all in JAMA. And I couldn't give this lecture or do this talk or video without including these 3 to be complete. And that was Remap-Cap, Codex, and Cape COVID. All 3 were randomized clinical trials, and you can see how many patients each one had, and you can see which corticosteroid they were focusing on. Hydrocortisone for Remap-Cap, dexamethasone for Codex, and Cape COVID was hydrocortisone. And the thing here is that after the publication of Recovery Trial, all the studies were terminated early because it was unethical to continue a randomized clinical trial comparing corticosteroid to placebo. And here's what those studies showed. So first of all, for Remap-Cap, we see an improvement in organ support free days, which is defined as free of respiratory or cardiovascular support in the ICU. This was a trend, not statistically significant. In Codex, they showed a decrease in ventilator-free days. This was statistically significant, but only a trend in improved mortality. And then when we look at Cape COVID, there was less treatment failure on day 21 and improved mortality, but again, this was a trend. And the reason we see lots of trends and not statistically significant is because they were all terminated early. Now, luckily, the 4th paper that got published that same day was the meta-analysis looking at 7 randomized clinical trials, and all of them are included in here. And Recovery Trial was by far and away the biggest. It was over 50% of the patients included in this meta-analysis. And what they ended up looking at was 1,703 patients that they could actually do a meta-analysis on. And they looked at 28-day all-cause mortality, and what they ended up finding is that steroids did better than usual care or placebo with a number needed to treat of 11. So again, in patients requiring oxygen, and that could be low flow, that could be high flow nasal cannula, non-invasive ventilation, oxymizers, invasive mechanical ventilation, ECMO, in all those patients, steroids seem to show benefit. In patients not requiring oxygen, there's a trend toward harm, so I would stay away from steroids in those patients. This is the QR code to Remap-Cap, Codex, Cape COVID, and the meta-analysis. For all of you who like stats and like to nerd out on the specifics, go check it out. Hold your camera up to the QR code and it should take you right there. Let's move on to our 4th topic, Remdesivir, and I gotta say right off the bat, Remdesivir is just a really expensive Tamiflu in my opinion. Reading all the papers, the evidence is kind of all over the place, but I don't want you to just take my word for it. I want to actually go through this and kind of break this down. So initially there was 3 randomized clinical trial. There was the Wang et al. Paper out of China. There was Act 1, which is by far and away the biggest randomized clinical trial we have on this paper. And then a randomized clinical trial looking at a 5-day course versus a 10-day course. And if we look at these individually, the Wang et al. Paper had about 230 patients. It was terminated early because they got control. They flattened their curve basically in China and they couldn't recruit any more patients. And they showed this clinical improvement of 2 days with Remdesivir, but this was a trend, not statistically significant. Act 1 published their preliminary results, so they also terminated early with about 1,000 patients, of which only 60 to 70% had 29-day outcomes. So there was another 30 to 40% that we didn't have results for. They actually just this past Friday published the final results like 150 days after this prelim publication, and we'll get to that in just a second. But in their prelim study, they showed clinical improvement of 4 days. And then finally, 5 days versus 10 days was about 400 patients. And they showed that the 5-day did better than the 10-day with less adverse events, specifically less acute kidney injury. Now, Act 1, I said, was the largest randomized clinical trial. I said it was about 1,000 patients. The final paper was actually just published this last Friday, so it actually ended up being about 1,600 patients. Is no longer terminated early because they followed these patients out to 29 days. And the clinical improvement actually went up by 1 day, so from 4 days to 5 days. The one thing that held true in both the prelim and the final report is that there was no real benefit in these patients in terms of clinical improvement in patients requiring high flow, non-invasive, invasive mechanical ventilation, or ECMO. The prelim paper showed a trend toward improved 14-day mortality, but ultimately when we finally followed 100% of the population out to 29 days, this was no longer statistically significant. We actually don't see an improvement in mortality. Here's all 3 of those papers, QR codes for you. The Wang et al. Paper is the one out of China. Act 1, which by the way, I've updated the post with the final results with this new publication that just came out, and then 5-day versus 10-day. Now, I was again getting ready to give this talk, and then a 4th randomized clinical trial came out looking at 5 days versus 10 days versus standard care of Remdesivir, and it was in patients with moderate COVID-19. And the way they defined this is they had pulmonary infiltrates on their imaging and then a room air oxygen saturation of greater than 94%. And this was done in 105 hospitals with just over 500 patients. And they were just looking for an odds of better clinical status on day 11. So were they feeling better faster on day 11? And it looks like the 5-day did better than the 10-day. But the thing that's really head scratching for me is that when you look at the 5-day group, 5 days got 5 days of treatment, and the 10-day group, 6 days of treatment. And so really, the 5-day and 10-day group, there's no real big difference other than 1 day. So you wouldn't expect to see a difference. So either this study wasn't powered correctly, or this is just statistical noise, or Remdesivir is not as good as we think it is. This is the QR code to that final randomized clinical trial, and I really think it's worth going and taking a look at it specifically for the details, because it really isn't a comparison of 5 days versus 10 days. I mean, the 5 days is equal to 10 days when you look at the course of what they took. Now, putting all the results of Remdesivir together, so it only comes as an IV formulation, so we're not going to be able to admit everybody to the hospital who gets COVID positive. And let's be honest, 80% of people will get COVID, might not feel great, but they'll completely recover without any untoward effects. So no oxygen, not an option for Remdesivir. I've already said the best randomized clinical trial doesn't really show improvement in patients requiring the most. So the late pulmonary phase and the inflammatory phase of disease, we don't really see much benefit. So there's going to be this small window of benefit, which is patients on low flow oxygen, just requiring nasal cannula. The other thing we have to balance here is the cost of Remdesivir, and $3,100 for a 5-day course is not cheap. And so you can see why I call this an expensive Tamiflu. It's really expensive. It makes you feel better maybe a few days faster in a limited population. It has no mortality benefit, and it does have adverse effects like acute kidney injury, which these patients develop without our help from remdesivir. So let's move on to our fifth topic, which is convalescent plasma. The first paper is a randomized clinical trial which looks at 7 medical centers in China. It was 100 patients, and it looked at time to clinical improvement. Now, this study also got terminated early, again, flattening of the curve, which is unfortunate because really could have used this information. But the one thing they did that was interesting is that model I presented to you at the beginning, looking at pulmonary and inflammatory phase, they kind of broke these patients up into those groups. If you look at the severe COVID-19 group, respiratory distress and/or hypoxemia, respiratory rate greater than or equal to 30 breaths per minute, oxygen saturation less than 93% on room air, and a PF ratio of less than 300. If we look at life-threatening COVID, these are the patients who are in shock, multi-organ failure, and requiring invasive mechanical ventilation. So they kind of already broke this up for us. And what we see with convalescent plasma compared to placebo is we see this trend toward clinical improvement with convalescent plasma. And really what we see is a bigger improvement in patients in severe disease, so earlier in illness, than we do in patients with life-threatening disease, so kind of that inflammatory phase of disease. And there was this trend toward 28-day mortality benefit, but again, it was a trend. Study was terminated early, so not statistically significant. So here's the QR code to that randomized clinical trial. Now, a far bigger study actually just got released a few weeks ago called the U.S. Expanded Access Program. This is a preprint, so it's not been peer-reviewed and it's not been officially published in a journal. But I think the results will hold true and it's worth going over. So this is over 35,000 patients, and they look to answer 2 questions. Does giving it earlier improve outcomes compared to giving it later? And if we look at IgG titers of convalescent plasma, is low, medium, or high more beneficial than the others? Now, this is an observational trial, so we have no placebo group to compare this to. So I have no idea that if we give convalescent plasma that it would actually do better than standard care. But for people who are giving convalescent plasma, here's what I can tell you. Giving it earlier is better than giving it later. And a higher IgG titer is better than a medium and low IgG titer. So if you're doing it, the point is that we need to be quantifying our IgG titers and we need to be giving it earlier in disease. So I want to end this talk with looking at some interesting trends from this U.S. Expanded Access Program study. And they looked at a bunch of different things that we've been doing since early in the pandemic through July. I specifically want to focus on invasive mechanical ventilation, hydroxychloroquine, remdesivir, and steroids. So if we look at invasive mechanical ventilation and hydroxychloroquine, we can see that there's a huge drop-off from beginning of the pandemic till the end of the pandemic. And I think early on, a lot of us were fearful of if we didn't intubate these patients, they would tire out. If we didn't secure their airway, they would aerosolize and we would catch COVID. And I think that we weren't using things like high flow nasal cannula and non-invasive ventilation. So you can see that we've started gaining some more comfort with that. And so intubating early has kind of started falling by the wayside. Hydroxychloroquine, obviously early studies said maybe a reduction in viral load. We've subsequently had multiple studies. I know it's been kind of a mess with retractions and peer review, but ultimately I think people are on board now. Hydroxychloroquine really doesn't give us any benefit in this disease. Remdesivir, early on in the pandemic, many people felt like it was an antiviral looking for a disease. I still think it's an expensive Tamiflu, but from the results of the Act 1 trial, maybe in a very specific population, we can reduce the potential for getting worse and clinical improvement. And so we see an uptick there. And then steroids is really interesting because we see this kind of 50-50 split throughout this part of the pandemic. But I think since we've had more randomized clinical trials published now showing benefit, I think if we followed this through to September, October, we would see those numbers going up. So there you go. Part 1, COVID-19, a summary of the evidence on 5 topics. And stay tuned. I'll be working on a second video for you, part 2, where we go over some more topics. Hope you guys enjoyed this. Please leave me your questions and always enjoy doing this. It makes me a better doctor and hopefully it helps a lot of you. Thank you so much. And be sure to check out Rebel EM at www.rebelem.com. Again, free website, shameless plug, but you can get all this information there as well. Until next time.